concept. The formula is slightly different. You do need to know these formulas. They're very simple formulas, but in the end, I still don't make you do calculations with them. You just need to understand conceptually how it is. So basically, there's just the addition of this number 2 here, so 2t equals PR instead of t equals PR. That means that as that radius increases, the wall tension is twofold increased in comparison. So it's more of a factor even than it is for cylinders. So as the sphere expands its radius, the tension in the wall structure increases to a factor of 2. But once again, tension is directly proportional to radius. So here's a perfect example of this. Now we do understand this in something we've always understood, but law of LAPLACE is the explanation of it. For the left ventricle, the greater the filling pressure, meaning assuming a normal compliant ventricle, okay, because you can have high filling pressure without any more size, okay, for a bad heart, okay, but the greater the filling pressure, the greater the tension in the ventricular wall. That's also explained by law of LAPLACE, but if you then also have that filling pressure increase because of more fill, the volume or the radius of that ventricle gets larger, you're also going to have much more tension. So when we talk about Frank-Starling's curve, you've got that greater size, and then therefore greater tension, and then greater ejection. Does anybody want to give me the definition of Frank-Starling's law? Anybody want to crack at it? Yeah, okay.
The further that you stretch cardiac tissue, the harder the contraction will be.
Okay. It's not too far off. Okay, how about this? What are the 2 variables? Stroke volume? And what? So stroke volume is directly proportional to?
Yeah, left end diastolic pressure, probably.
Left end diastolic pressure.
Or it could be even right. I mean.
Well, this is true, but not exactly Frank-Starling's law. You actually, the first part of what you said was more accurate. Stroke volume is directly proportional to?
Contractility?
No. Contractility is like another piece of the puzzle that's not stretch. Yeah.
Is it the elasticity?
What did you say?
To stretch.
Stretch. So let's actually say sarcomere length.
Oh.
Which you mentioned, like you said, muscle tissues.
Yeah.
Right,
Yeah. The further you stretch them, the harder they're going to.
So actually, when you stretch out that muscle, right, which happens as you get the ventricular wall larger, that is directly proportional to stroke volume. Okay, and so this is also explained with law of LAPLACE, that as you increase radius, which is the same concept, you're going to have a greater wall tension and greater ability to have that contraction. Be careful with the term contractility, because contractility has nothing to do with the size or the fill of the ventricle. Contractility is all about, so you can have the same size ventricle, the same, 2 patients with the same volume in that ventricle, the same everything, but if you give one of them a beta-1 agonist, that same everything will contract more strongly, because contractility is that intensity of the contraction. It's not something that necessarily has to do with any of the other. My point being, okay, you have a patient who's dry, and you say, I'm going to give them volume. By giving them volume, you are not affecting contractility at all. They're going to have greater stroke volume. They're going to have greater cardiac output, but it's all because of this stuff that we're talking about today, and nothing to do with that intensity of contraction of the muscle. You take the same patient that's dry, and you give them a beta-1 agonist, is their stroke volume going to go up? It could. Is the cardiac output going up? It could, but only because what's there gets more strongly contracted than before because of the beta-1 agonist. Okay. Now, is that the best way to treat that patient? No. Okay. So, but just and I'm not saying you're confusing that, but I'm just saying I have seen it confused many times. Know the difference between contractility and stretch. And inotropes affect which?
Contractility.
Only.
Yeah.
Only contractility. So when you think of an inotrope, we're talking about that ability for that muscle or that intensity of that muscle to contract. When we talk about volume or stretch, we're talking about volume and stretch. Law of LAPLACE, Frank Starling's law. So Frank Starling's law does not talk about contractility. Okay? Your ability to be able to look at your patient and pull all those pieces of information in and make a decision about what's in the best interest of your patient is where it's all at. Hey, this patient needs an inotrope. This patient needs volume. This patient needs afterload reduction. Those kinds of things is what's the true mastery. And those of you who have like more CVICU experience generally have a little bit of an edge at this point in the program because you had to do those kind of things. Or maybe if you've had some, you've done a lot of sepsis patients or whatever, you know. And those of you who have it, you'll get it. You just make sure if you haven't, make sure you review that stuff even more. Okay. That's more by this summer kind of stuff. Okay. You don't have to have that just yet. So, all right. Okay. The law of LaPlace states that 2T equals PR or P equals 2T over R. That's just algebra there for you. Pressure is the descending pressures within the alveolus, defined as dynes per centimeter. You will get things like dynes in your forced gravity pressure lecture. I do expect you to be able to know your unit. You know, like when you see a dyne, that is a representation of what, and that a Newton and a dyne are the same measure, just one is 1,000 of the other.
Yeah.
You know, stuff like that.
Yeah.
So
Yeah,
in other words, dyne is a measure of force. You'll learn that if you don't already. Okay. But that pressure is force over an area. So T is the surface tension of the alveolar fluid in dynes per centimeter, and R is the radius of the alveolus. The relationship shows that the pressure needed to expand an alveolus is 1, directly proportional to the surface tension, and 2, inversely proportional to the radius. What does all that mean? So that means if the radius of the alveoli is small, you're going to need more or less tension. Well, let's talk about pressure first. If the radius is small, are you going to need more pressure or less pressure to keep that tension there? As R goes down, P needs to go up. Okay? But at the same time, if R is going down, what's happening to the tension, the surface tension of that alveolar fluid? It's going down. So, alveoli are unique spheres because they have a fluid in them. So here's the problem with all of the law of LaPlace is when we talk about alveoli, they're not just as simple as talking about a sphere. There's something going on in there that's very unique, and it's this water. So water has surface tension. So I get to do a little chemistry here. I love when there's confusion going on here. So. Slightly off of it. So this is water, right? HOH. And what am I drawing here? What is this thing called?
Dipole?
Dipole interaction. And when I do this, what am I trying to say?
Polarity.
Talking about polarity here, and like the slightly negative versus a slightly side. You're like, oh, it's back. Yeah. Especially not with me, right? So it's still here. So when you have water, water has a polarity to it. So in a three-dimensional space, water is a polar molecule. So when you get another water molecule around here, it'll orient this way. Not the H's over on this side, because it wants to form this, what kind of bond?
Hydrogen.
Hydrogen bond from one water molecule to the next. Is that a dispersing bond or an attracting bond?
It's attracting.
It's an attracting bond, right? Because this slightly negative side of the oxygen, remember there's 4 electrons just sitting here on this side of the oxygen, plus the pull of the covalently shared electrons, there's a lot more electron negativity or negative side on this side than on this side of the molecule. It's very attractive to this hydrogen sitting here, which is slightly positive. So it's pulling together, pulling together, pulling together. So I keep using the example because it's just my best example, but it becomes less and less relevant based on what I said earlier, where more and more of my patients have birth dates before mine. Many of you can't relate to this, but you know, when I was a teenager, it was really cool if you could wax your car, and then when you threw water on it, it formed these nice beads. You know, the beads were cool, man. You look at my beads, they're that big around, you know, because turtle wax was not cut. You had to use something way better than turtle wax to get good beads. But you know, now everything you just want the water to run right off, because reality is beads just let the watermarks. You know, you just have the residual stuff on there. Anybody have the bead story? Yeah? Yeah. Okay. So, yeah, the rest of you can't relate to it at all. But what would happen is the beads would allow water to do what it naturally wants to do, where you would literally form on the surface of the hood a bubble. Why does that bubble occur? Because of this. So all these water molecules that are in this, are oriented in such a way to pull themselves together, and pull themselves together, and pull themselves together. And the wax would change that, that interaction with the surface to allow it to happen more. But it happens everywhere we go. It happens when you open up when you start your IV tubing, and the best example is the microtubing. When you have that microtubing, you can see that bubble actually formed much larger than even that little needle that's sticking in there. And you see that. Well, why doesn't it just come out straight in like a stream? Why does it form that bubble to begin with? Surface tension. Because all those water molecules are attracted to each other. So the one that's on the bottom, instead of just going, it stays, it holds on, it's holding on to the ceiling, right? So that's what's happening. So here you have your alveoli. And you have all these water molecules, and there's some that are in vapor form here, but the ones that are in liquid form are more on the surface. They're pulling on each other. The O's are interacting with the H's, pulling themselves to each other, and that's what surface tension does in our alveoli. Is that good? Is that helpful? When the alveoli are shrunk. Atelectasis. So, yes, we need the water there, but that's like not why we need the water there. Yeah.
So that's what surfactant.
Yeah, you're jumping ahead on me, but yes, that's exactly where surfactant comes in. All right, so the natural thing that happens in alveoli is that surface tension, the T part of Law of LAPLACE, says, so when T is high, then R is small, or better yet, when R is small, T is small. So actually, Law of LAPLACE says that the smaller alveoli are less likely to collapse. The big alveoli are more likely to collapse. All right. So in alveoli, surface tension is the same thing as that wall tension, or the T in the formula. So you can even see that here in this picture. You see that color, okay? That's because of surface tension of water. So small alveolar spheres would be more difficult to expand than large ones Did I say it backwards? So if R is small, you need more pressure to keep them open. The smaller alveoli are more likely to collapse. It gets really confusing because you got three factors here. Okay, so but the smaller alveoli are more likely to collapse. Forget what the rest of it. So
which one, the R is small, the smaller the T?
probably, yeah.
Okay.
Bottom line is, in a practical sense, if radius is small, you're more likely to have atelectasis. And for sure, with all alveoli, water surface tension is not helpful. It causes atelectasis of all alveoli. And that's where surfactant comes in. Surfactant is like that antidote to the problem. It changes those interactions in the surface and keeps that from occurring. So without surfactant, we would have much more atelectasis than we do. Yeah.
Is that what people smoke Tide Pods?
What's that?
Is that what people are smoking Tide Pods? To get surfactant? I'm just kidding.
Is there so? I just saw this recently. Like there's like, are there Tide Pods?
I thought they were
like,
eating them. I
There's
don't
like
know.
some crazy people eating them and stuff or something.
Yeah.
They're trying to are they trying to prove how long they can go without getting sick, or what's the deal?
It happens almost immediately. It's like their new challenge.
Yeah, but I mean, is there any like benefit of
No, it all
chewing a Tide
started.
Pod?
No, it all started with like, people were like putting them on pizzas, like topping,
Yeah.
and then suddenly it became a challenge. Let's see if we can actually put it in our mouth.
But see, we can do it, but not
Yeah.
because it's not
No,
like it's
there's
getting
no-
high or
no,
anything
no.
crazy.
I've only seen boys do it, right? It's only
Well,
boys.
because boys are the only ones who do stupid stuff like that. I mean, really, back in my day, it was can you eat a worm, Who was the kid in the playground who would be willing to eat a worm, But now it's Tide Pods,
Yeah, unique chemicals.
Yeah, so maybe you get a little more surfactant, assuming that you inhaled them, yes, so, yeah, whatever. Jeez. But on another note, Tide Pods are awesome. But no, not Tide, I'm thinking of the dishwasher ones. I love the dishwasher.
Those are those cascades.
They are awesome. Like before that, I used to pour the Cascade in, and I always had the residual film. I don't know what is possible.
We can start a new challenge and put those on salad.
Yeah, that's a great idea. Put that in your wellness plans. Okay, so surfactant is composed of that stuff there, and but basically things like lecithin and all, and it's secreted by alveolar epithelium's greater alveolar type 2 cells. And so if you don't have enough surfactant, you can develop respiratory distress syndrome, formerly known as hyaline membrane disease, and that's something that's an issue for like premature newborns. So one of the issues is they don't have enough surfactant, so you got to try to.
Is it the same thing with cystic fibrosis or something similar?
I don't know. It's been so long since I
Well,
looked at it.
CF is a chloride.
I think
Chlorine.
that they're excreting stuff. Like, I don't know.
Yeah.
Anybody know?
It's a chloride issue.
Yeah, like
Yeah.
excess mucus production, that kind of thing. So don't think it's the same thing. But
You can get a shot if you're going to be delivering.
yes. Yeah, that's when they give them betamethasone and that kind of thing to try to stimulate all that. So basically, Law of LaPlace explains the atelectasis. Surfactant is why Law of LaPlace doesn't apply, because we actually get plenty of surfactant excreted into especially our smaller alveoli, so it becomes the great equalizer. Surfactant. So Law of LaPlace doesn't explain why everything's great. Surfactant explains why Law of LaPlace doesn't mess everything up. Is the better way to think of it when it comes to your alveoli. All right. Then we have this stuff right here at the end of the lecture that how has something to do with it all, but also it's just in and of itself very valuable. Okay? Your next class is at 2:15, right? Okay, so so when we talk about VQ mismatch, so ventilation divided by perfusion. So we're talking about the movement of air in and out of our alveoli, and then the movement of blood through the capillaries. We never have it perfect. We never have an equal amount. So generally, you have a ratio of 4 to 5. You know, if everything's normal, blood keeps flowing, but do you ventilate every alveoli adequately? No. So generally, a normal person will have 80% of their alveoli that are properly perfused actually ventilated. Okay? You can try to hyperventilate yourself, take huge tidal volumes to try to make that a little better than 0.8. But generally, that 0.8 comes from a ratio of 4 to 5. 4 divided by 5. So that gets way worse when we positive pressure ventilate a patient. Because now, instead of getting that negative pressure and pulling all that gas down into the best alveoli, it's only to the closest ones, the top of the lungs. Of course, it depends on your patient positioning. You get a lot of this in your Principles 3 course. But the alveolar gas equation relates P, when you see a big A, that's alveolar, O2 to FiO2. And so you can do all this calculation, which I don't make you do that, but I do expect you to know this for sure. And this is very useful. I have a quick story where I was with actually Dr. Welliver, it was Mr. Welliver at the time. And it was kind of maybe a couple months from where you are right now. And he says, "What do you think? You think the patient is ventilating and oxygenating adequately?" And I look up and I see a SAT of 98%. I see a tidal volume of 400. Respiratory rate, I don't know, 16, whatever, I don't know. And I'm thinking, I can't think of anything wrong, and try not to do this, if he's asking, it must be for a reason. Because sometimes I'm telling you, if you work with me, I will ask you if you think everything's fine, and everything is fine. I'm just wondering if you think so. So you sit there going, oh, it must be something, must be something, must be something. Yeah. Well, in this case, I couldn't think of anything, so I said, yeah, I think everything's fine. Really? You think that's fine? I don't do that to you, by the way. He did. Anyway, what do you mean the patient's fine? Their SAT's 98%. I'm thinking, well, gosh, I'm just lots of very normal people at 98%. Put his pulse ox on me right now, I'm probably 97. It sounds pretty good to me. And I said, oh, yeah, and of course, I got this lecture like the next week. It's probably why he asked, because he was about to give the lecture. And so I'm thinking that's fine. Well, guess what? That patient was also on 50% oxygen. So when you use the alveolar gas equation, you can come up with a shortcut that basically says if the FiO2 is around, let's say it's 40%, you multiply FiO2 by 5, and that should give you a predicted P little a O2. Arterial. So what that means is if the patient is on 40%, they should have a PaO2 of what? 200. Mm-hmm. How many patients with PaO2 of 200 will have a oxygen saturation of 98%? A lot, little, almost none.
I think a lot. A lot. Normal PaO2 is like 100.
If you have a PaO2 of 200, what do you think your SATs are? If everything else is normal, it should be about 100.
Yeah.
Should be 100. Yeah. So if you have an oxygen saturation of 97%, it's highly unlikely your PaO2 is 200. My patient was on like right around 50%. Let's say it was a set of 60, so it's like 55%. So we should probably more follow this. My patient should have had a PaO2 around 300, yet their SATs were 97% of the time. That means their PaO2 was not 300, nor should it have been, because we all have VQ mismatches. And when we're under anesthesia, it gets way worse. And so the whole point was, what he was looking for me to say was, no, we're not adequate. Are we about as adequate as we can be, considering circumstances we want the patient to be spontaneously ventilating? So if I overdrive them or I try to give them too big a tidal volumes, they might quit breathing and they're on LMA, which really let them breathe on their own, I could have said all that, but what I said was the patient's fine. And that wasn't the best answer. Did I make it through the program? Even with that enhancement, horrific enhancement, wasn't horrific, but it's a good one that I remember to this day. And so my point being is, you should know that your patients will not achieve this typically because we are poisoning them. We're poisoning them, and we're keeping them from breathing adequately, and we're doing all these things to the patient that makes this not true. But this is what we would like to see. This is what it should be. So if I were to give one of you 50% oxygen and say breathe normally, you'd probably get somewhere close to 200. But if I give you anesthesia, positive pressure ventilate you, put you in an abdominal patient positioning, Trendelenburg, whatever, you're not going to get this. Yeah.
In the ICU, isn't that how you see if someone has acute lung injury or the FiO2 to PaO2 ratio?
It might be. I never did that as an ICU nurse. Sounds good. You can definitely tell if there's something wrong there, but there are other factors that can affect that. Body habitus, whether or not you're giving an adequate tidal volume for their body habitus, all that kind of stuff can be factors as well. But I'm sure somebody's come up with some kind of formula in ICU to use. I just haven't used that. So, but all these things are factors. And so one of the things I encourage you to do is when you get an ABG, you have a patient over here like an ABG, ask think of this formula and see how far off you are. Because you actually have a PaO2. Because even the pulse ox is not foolproof. There's factors where it can be inaccurate. Whereas an ABG is fairly accurate. So because they're calibrated all the time, that kind of thing. So just see how far you're off. And every time you'll get somebody you get an ABG on, they're on 100% oxygen, and their PaO2 is 550. That's pretty good. That's almost exactly what it should be. And when you see that, you go, okay, this patient does not have a problem with ventilation. Well, with perfusion and their VQ mismatch is great. That kind of stuff. So, other questions about that? Yeah.
Yeah. So if your SAT is like 98, right?
Uh-huh.
And something is really going on?
Yeah.
What indication would you have that you need to be drawing an ABG? Like, the person's satting fine.
So like in this case, my patient was just like every other patient. Nothing was wrong with the patient any different than every patient we put under anesthesia, because we're poisoning them. So there would be rarely an indication, hey, we need ABG, the patient's SAT's 98%. Now I'll say that if their SAT's 95% and they're on 100% FiO2 and their ventilation is fantastic, we're giving them 10-liter minute ventilation and all like that, and they're 95%, and I'm about to do a really long case in the prone position, yeah, I might want to get an ABG just to see, because if I get that ABG and their PaO2 is 60,
yeah.
And I'm about to do this 10-hour prone case, something's wrong, But as far as to answer the question, there's just not an easy way to answer that. You have to ask yourself that whole thing. So I have many times let a 95% ride when I'm doing a quick case in the supine position where I have access to everything I need to and that kind of thing. Whereas there was a case I can remember where I was giving this patient plenty of volume and they were sat at 93% or something. I was about to flip them prone and do this big, huge spine case, and we were on 100%. And I said, no, I'm not letting this ride at all. We got an ABG. The PaO2 was 50. And we canceled the case. They got really upset upstairs. They told us that the patient really needed to have that surgery in the ICU, Turned out the patient had a massive hemothorax that had developed overnight.
Gotcha.
Because I'm sitting there going, there's just no way, this makes no sense. And I'm going to get in this, have a flight open back, and if it gets worse, what's going to happen? So every situation is different. That was a long time. I remember.